All right, so let's start. Rheumatology is part of your clinical medicine courses, and kind of goes, believe it or not, it goes hand in hand with musculoskeletal. You're going to see a lot of questions on your boards that are going to kind of present as musculoskeletal and tons of rheumatology will be involved. Believe it or not, nowadays, when I start looking at the board questions, and not just board questions, but clinical questions that are out there, you're going to see a lot of rheumatology. Rheumatology wasn't that prominent, and you didn't know too much about it. But once COVID came around, I have to tell you, it really came to the forefront. We find out a lot of autoimmune diseases that fall under rheumatology. Ever since past COVID, everybody's having autoimmune diseases that are coming up. And if you go out to like the Midwest and out the West Coast, they actually have COVID clinics now. And in those COVID clinics, they discuss a lot of these autoimmune diseases. We'll discuss all these as we move along, but that will eventually come. Right now, we just need to get the basic stuff out of the way. Things like osteoarthritis, rheumatoid arthritis, and things of that nature. And I can guarantee you're going to see this everywhere you go. If you guys go out there in clinical medicine, in emergency medicine, whichever aspect of medicine you're going to go ahead and work it, you will see this stuff, and I guarantee. Okay? So, next thing. There's only one exam for this class and only one. There is no two exams, one exam you have to pass, and that's it. If you fail this exam, I will find you and I will key your car. I honestly mean it. There's no reason why you should fail it. Everything you need to know is right from these slides. Okay? So if you study these slides, you should be good to go. These slides are going to look pretty easy as you go through them. And then what you're going to do is this. You're going to wait to the last minute to study stuff because it's going to make it seem like it's very, very easy. If you're going to study it the night before the exam, you're not going to do so well. So keep that in mind when you're preparing for this exam. Give yourself about 2 or 3 days to study for this, and then you should be fine. Fair enough? So, just warning out there. A lot of people do very, very well, and then all of a sudden there's a handful of people that don't do well. Then they get me in the hallway and they're like, oh, this exam was so tricky. And I'm like, I don't know how it was so tricky when, like 5 people got 100 on the class. So so I don't understand. If 5 students or 4 students or even 1 student gets 100, then there's nothing wrong with the exam. If they did. So keep that in mind, please. Just kind of throwing it out there. All right. Any questions? Let me know. But once again, only one exam, and we move forward. So, what is osteoarthritis, and why does it fall under the realm of rheumatology? Now, I know it sounds crazy, and you might think that I'm saying that just because I teach this class, but that's not so the case. I've been doing clinical medicine for a long, long time, and this is what happens when patients have seen all kinds of practitioners, doctors, and so forth, and nobody knows what's going on with them. These patients end up at 2 places. They usually end up at an infection, ID doctor, or they end up at a rheumatology office. And that's when they kind of figure out exactly what's going on. Okay? So I'm not saying cardiology is not a smart field. Of course it is. Absolutely it is. But the mystery of all this comes into places when nobody can figure out what's going on with you. You have fevers of unknown origin. You have a white count that's climbing and nobody knows. Guess what? They always end up at the ID office, or they always end up at the rheumatology office. And then we do a slew of tests, and right there the problem comes into place. The majority of times, it's usually an autoimmune problem. Right? So let's talk about osteoarthritis first. You cannot sit in this room and never hear of osteoarthritis. When you get out there and start working, you'll know what osteoarthritis is. You're going to go to your family barbecue, and you'll know what osteoarthritis is. You're going to go to your grandma's house, you'll know what osteoarthritis is. And you might say, what do you mean, grandma's house? Well, you're going to go to your grandma's house, and she's going to be like, no, I don't feel like going out today. Why is that, grandma? Well, I know it's going to be raining tomorrow, so I need to rest. Why does grandma, who doesn't have a TV, already know that it's going to be raining outside? And you know what? Grandma's absolutely right. We'll talk about that so that way it can make sense. I'm going to try to make this class fun so that way it's easily understandable. But before we get to the signs and symptoms, how patients present, let's talk about exactly what's going on. Osteoarthritis is an inflammatory condition that causes pain in the body, arthritic pain in the body. Why does it cause arthritic pain? Because the inflammation is caused by destruction of cartilage within joint lines. So when the joint lines and the cartilage between these joint lines disappears for whatever reasons it could be, then two bones start touching each other. It causes inflammation and causes pain within that joint. And you start seeing changes within that joint line. Okay? So, what causes this? Is it like you wake up one morning and you're 40 years old and you have like a bad cold and all of a sudden you're like, oh God, my arthritis, I think I got it. Nope, it's not like that. It's not a bacterial agent, it's not a viral agent, but the etiology is unknown. As we go through most of these slides throughout all of rheumatology, we'll constantly see that over and over again. What is the etiology? Well, we don't know. All right, well, there's no etiology, then are there risk factors? Is there something that contributes to this underlying problem? And that is always a yes. So, what are the risk factors? Well, we know aging over time does it. You might say, how? Well, think about it. Let's say if you have a runner, you've been running for 15 years or 20 years or 30 years, 40 years, eventually the cartilage between your knees is going to start shaving away. In your arm, if you're a baseball player, you're constantly swinging, you're constantly moving those joints all the time. And when that happens, the cartilage between those starts getting to what? Over time, shaves away, which makes sense. Well, what's some other reasons? Trauma might do it. Obesity might do it. And then there's a whole list of them. And you might say, how will trauma do it? Well, let's say I take a bat and I swing and I hit him right in the elbow right here. And I break his elbow. My whole point is to break his elbow, and I've done so. He's going to go down to the ER and just say, yep, I got smacked in the elbow here. We're going to get an x-ray, and the x-ray is going to show that it's a broken bone. So what I'm trying to tell you is, while you're sitting here, your bone is nice and clean. It's nice, clean cortex like this. If I break it, then your body's going to start healing itself. When it starts healing itself, it will never heal as clean as this line right here. It just never will. You can see a bony growth that's going to look abnormal and so forth. And then over time, that not so clean bone is going to start causing what? Arthritic changes over time. So that you might see in trauma. Obesity. I'll use that for the last example and move forward. If you have a high BMI, you have to understand gravity is always pulling you down. And the weight of your body is making it worse. And for example, if you have cartilage in your knees and you're constantly walking, over time, that pressure on top of your body will cause the cartilage between your knees to start shaving away much quicker. It's like me pushing down. And it's going to shave away much faster. So you kind of see how these risk factors play a very, very important role. There's congenital problems like Paget's disease, where you automatically have too much bone growth. And too much bone in certain areas, especially joint lines, just makes the bone unstable. We'll talk about that more. But let's talk about what's happening at the cellular level. Can't avoid that. We know chondrocytes produce, more cytokines. So when you have a lot of inflammation, chondrocytes starting to be formed. Starting to come into place. These chondrocytes start making cytokines. Cytokines are bad for the bone. These cytokines will go in there and they will start breaking down the cartilage. These are for patients over years and years and years. Not so much of the trauma patients. And then these cytokines, as they break down the cartilage is gone, and the joint space between those two bones starts to shrink, starts to get narrow. Then you have reactive bone changes, meaning bone on bone. You start having crepitus. When that crepitus happens, you're constantly in pain. You probably had a family member, maybe your parents, grandparents, who had knee replacement surgery and so forth because the cartilage is gone, and every time they walk, it's bone on bone. Okay? So when you have that bone on bone changes, you're going to start seeing crepitus within the bones, decreased range of motion, and most importantly, these hypertrophic changes. And that over time causes more problems, like joint effusion. You'll see when you're working in the ER, when you're working in the orthopedics office, wherever you might be, patients will come in and their knee will be swollen. You put your finger on it, like, ooh, there's a lot of fluid in there. The fluid is because this hypertrophic changes and the capsule breaks and all the fluid starts leaking out. What you simply do is you stick a needle in there and aspirate it all out. But then it comes back. So keep that in mind. So what's happening now? Now that we know at the cellular level what's happening with these cytokines, and we know the cartilage is being broken down, well, what will these patients complain of? They come to your office. You have a 48-year-old male comes into your office and indicates that, hey, I've been cycling for years and years and years. And constantly over that time, my knees are starting to really, really hurt. Or I'm a runner. I've been running for years. All right, so what brings you in today? Well, I'm having a lot of joint pain. Where is it happening? It's happening in my knees. What happens? Well, every time I move, I feel like I can't move so much. Because every time I move, I feel this crackling in my knee or crepitus in my knee. They won't say those words, but they'll say, I feel like everything like hurts when I move. All right. Well, your question is going to start coming to places. All right. Well, there's a lot of form of arthritis. Obviously, you didn't fall. You didn't break a bone. You didn't injure yourself. There was no mechanism of injury. So I'm thinking that might be arthritis, but let me confirm. So joint pain, limited range of motion, these are weak symptoms. There's nothing really go by. You might say, I need to ask you some more information. Tell me what happens when you wake up in the morning. How long do these symptoms last? And that person might say, well, I don't know. I'll check it out next time. And next time I come in, I can let you know. Well, do me a favor. Check to see if it's 30 minutes or an hour. Why? Well, there's reasons for it. Because when I take my exam, I'll be able to figure out if it's osteoarthritis or rheumatoid arthritis. All right. So also know that pain worsens with activity at first, then over time it starts to get better. And then we come down to this barometric pressure changes. You remember your grandma or your grandpa? Oh, it's gonna rain tomorrow. I know it. How? My bones start hurting. Well, that makes sense. Think about it this way. If you're in a pool and all of a sudden you're going deep sea diving, the more deeper you go, what happens? The pressure builds up. And you might say, what do you mean the pressure builds up? Well, the pressure above you builds up. You remember those people who I took those small little, whatever the hell it was, that capsule, they went down?
Oh, yeah.
Remember when they went down to the Titanic? And what happened?
They died.
It's exploded to the pressure.
It kind of exploded, but what happened was it just pressurized, meaning squished together. The reason why it happened is because there was pressure above it. Same concept. If I have you stand up and say, I'm going to need you to hold on a gallon of water over your head. You're like, I can do that. Then I say, I'm going to give you another gallon. Then I might give you another gallon, another gallon. After a while, you're going to be like, that's too much water over my head. Same concept here. When the weather changes and the pressure in the atmosphere starts to get heavy, your grandma can feel it right away. Or your grandpa, he's going to say, well, I know the changes are bad out there. The air is heavy. If the air is heavy, then I can feel it within my joints. My knees hurt. My feet hurt. So when your grandma says that, or grandpa says that, they're 100% right. The concept is what you need to understand. Okay? Let's move along. So, anything else, Mr. Smith? Well, I told you I'm having this pain that lasts about 30 minutes in the morning, and then it starts to get better. All right. Where is it? Well, it's in my knees. All right. Anywhere else? Yes, it's my hands. No problem. Is it possible for me to see your hands? Sure. Why not? Look at the hands, and all of a sudden you're starting to see DIP joints and PIP joints swollen. Okay? Bouchard's nodes, Herbert's node. Well, how long has it been like that? Well, I got to tell you, it's been like that for a while, and this is what you might see. Now, why is it important that I asked and I mentioned PIP joints and DIP joints swollen? Because in rheumatoid arthritis, we only see PIP joints swollen. In rheumatoid arthritis, those symptoms usually last an hour and then start getting better. In osteoarthritis, it's only 30 minutes. That's how you differentiate between one and the other. And that's the reason why these slides are very important. Now, once again, your PIP joints and your DIP joints. Here you have your what? DIP joints being swollen. All right, now we're on to something. We have a case vignette that's starting to make sense. Decreased range of motion, some crepitus, some pain, 30 minutes, PIP, DIP. All right, we're on to something. All right, well, what else you want to do? All right, Mr. Smith, what I'm going to do is this. I see the problem. I have a feeling that it's osteoarthritis. What I'm going to do is I'm going to go and get some x-rays on it. Because the x-ray is going to tell me a lot. All right, well, what are you looking for in the x-ray? It's not like I felt like I broke anything. No, that's not what I'm looking for. What I'm looking for is these small changes. They'll tell me a lot. And that's how I'll be able to pick up what osteoarthritis looks like on an x-ray. Now, some radiologists might say osteoarthritic changes. And back in the days, they used to do that. You send in an x-ray of a person who's coughing, and it would say pneumonia. Good to go. It was very easy. Nowadays, radiologists don't write that stuff. For an x-ray that's looking for pneumonia, they might say infiltrates noted, consolidation noted in the right lung, clinical warrant, meaning you look it over more and you decide. Patient has a fever, lungs are rhonchi, then infiltrates are there. I didn't say it's pneumonia. You have to clinically decide if it's pneumonia. Same thing here. They might not say, hey, osteoarthritis. They might write down osteophyte formation, periarticular sclerosis, bony cysts noted. And you might say, okay, those are all the fancy words for someone who has osteoarthritis. You get the idea? So everybody's out to fend for themselves. Everybody wants to not get sued. So radiologists say, I didn't say it's osteoarthritis. I'm just telling you what I saw. You make that decision. So now on the x-rays that on the board, they might give you an x-ray finding, and they might write down these words. And those words are what you have to interpret as osteoarthritis or arthritic changes. Now, what are we looking for the x-ray? We have an x-ray, all those words are there, but what do they mean? Well, they mean exactly that. You remember this line that I drew right here? The cortex is nice and clean. Well, this is what I'm talking about. Look at the cortex here, nice and clean. But what I don't see that nice clean cortex is here. Would you agree? It's all like osteophytes over here. Notice how this is bone on bone. It shouldn't look like this. It should not. Matter of fact, it should look like this. Okay, but it doesn't. This is bone on bone. And here, all this is osteoarthritis. Here's another picture of an x-ray of a finger, moderate, severe. Notice how everything is bone to bone here. There's no nice clean line. Maybe here's a little bit clean line, but the rest is not. You see that? That's a picture of an osteoarthritis. And here is just terrible. Here is a knee. Knee literally bone to bone. And look right here, we actually see a smaller fracture right there. Because the bone keeps on hitting the top bone and it's causing pain. Here is a picture of a spine. Notice how you see a fracture here. Okay? And there is no vertebral discs in between. They're literally on top of each other. And this is exactly what it looks like, which is pretty serious. Here's a knee. Once again, you think that they're pretty much fused together, but they're not. This is a bad knee. Okay, there should be this much space here, and it's not. You can actually see that this person, the way they probably walk or run and so forth over years, all the pressures on this side of the knee. That's the reason why it's very, very important for what the shoes you wear and how you walk and so forth makes a major difference as you all age. Okay? So important. All right, so now that we diagnosed the patient, we looked at the x-rays, the question comes into place is, well, what do we do? Well, first things first, physical therapy. Get them out there and have them start moving around. The more they rest, even though there's pain there, the worse it's going to get. Now, exercise will help because it's going to help with the range of motion. And not just that, physical therapy will help because it'll strengthen the muscles around it. You strengthen the muscles around it, it kind of pulls the bone apart. And then you have range of motion. So keep that in mind. If the patient's overweight, weight reduction, analgesics, and then most importantly, non-weight bearing exercises like swimming and things of that nature. Okay? So they can take all the pressure off the knee. Now, analgesics is the first line of treatment. If that does not work, we move on to the second line, which is called NSAIDs, non-steroidal anti-inflammatory drugs. Medications like Bextra, Celebrex, Vioxx, things of that nature. They work and they're readily available. Vioxx is in red here because Vioxx has been pulled off the market. It was known to cause cardiac arrhythmias and heart attacks and so forth. So they pulled it off the market. Now, you might say, well, if it's pulled off the market, why do you have it here on a Friday afternoon and wasting my time? Why did you put it on there? Well, I'll give you an example. When I was working in the emergency room a while ago, there was a lady came in and she was still on Vioxx. I'm like, how are you on Vioxx? They put this stuff away like years ago. You're not supposed to have this shit. And she's like, oh, I get it, son. I'm like, I got a friend of mine who lives in Canada, and she gets them from up there someplace, and she mails them down to me. And I'm like, really? She's like, yep. And I'm like, you know, it's not causing the heart attacks. Like, I know. I read all about it. I'm not stupid. I'm like, all right. She was like 70 years old, and she was like looking at me like, you're crazy. I'm like, all right, but you shouldn't be taking it. Like, this is not okay. So you know what she tells me? And that's the reason why I still put it on there. She's like, do you know what the pain is like? And I'm like, no. She's like, I will take a heart attack over the pain that I have every morning when I wake up. So what do you think I want to do? And I'm like, all right, I guess it really is. Like it helps and the pain's really bad. Now you would think that pain from osteoarthritis is nothing. You take a little Tylenol, it goes away. For some people, it's not. For some people, it's very, very painful. And that's the whole point of putting this on here, putting this red, and telling you the little story. Because you have to be sympathetic to these patients that come in. Okay? All right, let's move along. NSAIDs not working. What's the next thing you do? Well, you give them steroids. Steroids like prednisone, dexamethasone, solumedrol. All those are a form of steroids that we give. Now the question comes into place, how do you give those steroids? Well, we give them injections into the knee, into the elbow, and that would work. They'll bring down the inflammation. You're good to go. They'll bring down the swelling. But my question to you is it okay for you to give them prednisone for like 1 week to bring down the inflammation, or you give them prednisone and they say, yeah, it works great. This is what I need. You tell me to stay off the Vioxx, I can do so. Like the old lady. And she thinks prednisone works. Why can't I just take prednisone every day so my pain can stay away all the time?
You can't take it long term.
Cannot take it long term because there's a lot of problems with long-term steroid use, meaning prednisone, things of that nature. But that's not even the most important thing. What I'm trying to tell you is this, that osteoarthritis is a localized problem. It is not a systemic problem. If it was a systemic problem, then giving oral steroids for a long time might be, maybe you can give it, but still no. Osteoarthritis is a localized problem. I took a bat, I hit him in the knee and the elbow, it's localized there. Localized problem only in my fingers, because I'm constantly using my fingers. Maybe that's the problem. You get the idea? It's not a systemic problem. All right, if the steroids are still not working, then obviously surgery is the next thing. If you have a bad hip and you're bone on bone causing crepitus, where you can see here the femur, the acetabulum, they're literally right on top of each other. There's no space in between, causing crepitus, two bones touching each other, very painful, then fine, no problem at all. Let's go ahead and get some surgery. Let's put an artificial hip in there, and we're moving along. Buy yourself another 15, 20 years, and we're good to go. And you'll be surprised how often these patients will get this done and be like, wow, unbelievable. I can actually move my hip or my knee, etc. Get it? Anything else? Anything else out there that will help? Yes, something called viscous injections. These are not hydrochloric, but complex sugar that we find already in the body. They're naturally made in the body, but over time they start to decrease. Well, what you can simply do is you can give these viscous injections within those joint lines. They're synthetically made and they work. They are FDA approved and they're great for knees that are secondary to osteoarthritis. They're given and they're readily given, and some people love them. They come back every 6 months and they get them and they're good to go. They're like, I don't need surgery. I don't need NSAIDs. I don't need to take any medications. They just work for me. Some people say it works. Some people say it does absolutely nothing for them. Once again, there are injections. You get about 3 to 5 weeks of injection, depending on which product you use. And what they simply do is these complex sugars, they lubricate the joint. You put them in there, they stay there, and they're housed there, and they tend to work. Will they always work? No. Some people say it does work. Okay? Any questions on osteoarthritis? I think we covered everything from at the cellular level all the way to what these patients will present. Yes.
Is there any reason you wouldn't like to start with that, or maybe do like second line?
So it's a great question. The insurance companies won't let you.
Oh,
it's out of pocket.
Well, no, some insurance companies will pay for it, but what they'll say is, "Hey, have you tried any other method?" So, like nowadays, you'll prescribe somebody medication. So, what happens is this, right? In clinical rotation, students will come in and they'll watch TV and they're like, "Oh, there's a brand new medication out there," and the commercial said that it's used for, I don't know, psoriatic arthritis. I see it all the time. Why can't we just give that? And I usually say, "You could. Do you know how much it is?" And they're like, "I don't know." They don't tell you in the infomercial how much medication it is. I said, "Why don't you prescribe the medication and see what happens?" You prescribe the medication, all of a sudden the insurance company will say, "No, you need a prior authorization." So you have to sit there for like an hour, do the prior authorization, and then they'll start asking you all kinds of questions in the prior authorization. Have you tried any other medications? Like, oh, do you know there's 7 other medications that you can use that are much, much cheaper? Have you used this one? Have you used that one? And you got to write down no, 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 no. The insurance companies know because they're the ones who pay for your medication. And I say, no, we never prescribed it. We never okayed it. So you're lying to us. Get the idea? They want you to use the medications that are cheap. So in this case, you can go ahead and put this as a first line resort, and then insurance companies will say, it's going to cost a little money. Why don't you try a little Celebrex first and see if that helps, and so forth and so forth. But eventually, when all else fails, you got to go to that. And you'll see that when you guys start working out there. There's a step towards everything. You can't just jump right into it. And the truth is, some people, they're just not okay with certain things. Like some people, they're not okay with just going to surgery right away. They need cardiac clearance. They need pulmonary clearance. There's all other kinds of comorbidity out there. And some people don't do well with injections. How many people do you guys know that don't like needles at all? They hate needles. My brother, no, can't give him an injection. He hasn't seen a doctor like he's 20 years. I'm like, you're crazy. You get it? So everyone is different, and you'll see that. And then there's other things, financial problems. You gotta understand. A lot of people don't have the money for this. They might have to pay out of pocket copay and so forth. And they're like, no, I can't afford that. Which is understandable. Okay? You'll see everything is a different fit for different patients. All right, let's move along to rheumatoid arthritis. It's also a form of arthritis, and it's much different than osteoarthritis. How is it different? Well, first things first, osteoarthritis is a localized problem. Rheumatoid arthritis is a systemic problem. When I say systemic problem, it's everywhere. It's in the body, therefore it hits the heart, lungs, skin, eyes, it hits everything. Does that mean everyone who has rheumatoid arthritis has all these problems? No. Some people might have just one. Some people might have just the joint pain. Some people have everything. It all depends. So, does rheumatoid arthritis, same concept, it goes after cartilage? No, it has nothing to do with cartilage. Instead, it has to do with diarthroidal joints. Any joint that has a synovial fluid lined around them or membrane around them, that's where rheumatoid arthritis goes after. So osteoarthritis, cartilage. Rheumatoid arthritis, slightly different. Now this part right here is just for musculoskeletal. But if it's here, then it's going after your whole body. Okay. So, what are we looking for? Put some facts out there. The facts is that it's a systemic problem, that it's a big problem here in the States. Alongside with that, it causes all kinds of issues, very vague symptoms like fatigue, fever, joint problems are permanent, they're non-reversible. And then most importantly, if you have all these systemic problems that are out there, it can cause premature death. It can knock off a few years right off your life, especially if you have all the systemic issues that go alongside with it. So let's get into it. If you have to start talking about epidemiology about anything, then you know things are not good. If they're at that level where the government or everybody else, CDC and so forth, they start tracking of how many people have it, how many people don't have it, chronic stages and so forth, that means it's up there. It's a big problem. So rheumatoid arthritis affects about 2 million people, roughly around 1% of the population. We see that majority of these patients, 60 to 75% of these patients are females. We don't know if there's some kind of link towards that, but we're getting to it. And 80% of these cases, usually between the ages of 35 and 50, and then off we go. So just a little epidemiology before we go into it. So what is the exact etiology of this? What's causing it? Do you wake up, get bit by a mosquito, and all of a sudden you're like, oh, I got rheumatoid arthritis? No. But we know that there's one thing that's definite, and that is a genetic predisposition. If your family members have it, your first degree relative, you're 4 more times likely to have rheumatoid arthritis, which is pretty serious. Now that there's more studies that are being done, and they're saying that there might be an initial trigger, and there might be an infectious agent that's starting to cause this. Exactly what? We don't know yet. But there's a lot of work that's being done towards this. So keep that in mind. So, what are these patients coming complaining of? Well, joint pain. That's the biggest one. It's always areas where there's synovial fluid that's involved. So that's okay. It's that it's always a PIP joints, meaning Bouchard's nodes. We tend to see these elbows, wrists, ankles, and feet. Once again, this is just musculoskeletal. And then when these linings get affected in those areas, there's a lot of pain, which is normal, you're gonna get swelling and some heat. Characteristic that you need to pay attention to is, as we mentioned before, differentiation between osteoarthritis and rheumatoid arthritis. It's very simple. These manifestations that we tend to see, they last greater than 1 hour. When we start talking about osteoarthritis, as we mentioned before, less than 30 minutes. That's key. So PIP joints, 1 hour and more. And this is what you'll start seeing. Here's your PIP joints being swollen, proximal joints. Now, I took this straight from the boards. Shouldn't be putting this on here, but it was on somebody's boards and I stole it fair and square. No, it's got it. Anything else? Is it just PIP joints? No, it gets more than that. We need to start talking about Jacob's neuropathy. And on the board, when I took my last board, they didn't say Jacob's neuropathy. Instead, they said patient presents with swan neck deformities of the fingers, ulnar deviation of the hands. I'm like, huh? Flying by that case vignette. I'm like, wait, let's go back. And I'm thinking like it's a deformity. Somebody got hit by a car. That's not what the 58-year-old female gets into a car accident, presents to the ER. On a physical examination, we start seeing this stuff. And I'm like, what? I remember seeing this in rheumatoid arthritis. You see what I'm saying? They're trying to trick you. It's car accident, nobody cares about car accident. She was complaining of pain. So the case vignette made you think like, uh-oh, it was all the car accident that made the pain when it wasn't. So once again, know the Jacob's neuropathy, know the Boutonniere's deformities of the thumbs, ulnar deviations of the MCPs, and the swan neck deformities of the distal phalanges. Those are important. And what that looks like is here. That's what it looks like. And then it also looks like that. And if it's not in the hands, it's in the feet. And here, we see exactly all that, but just in the feet. So, right? Now that we spoke about some of the musculoskeletal issues, let's start talking about systemic issues. Now, on the exam, there's not going to be too much of this extra-articular manifestation, especially in the heart, lungs, and GI, because they're vague. Problem comes into place is when these patients are seen at the hospital or clinical settings, we're treating these problems. But then certain ones of them stand out, and they're so important. And I'll point out the ones that stand out. So, patient comes into your hospital, all of a sudden the patient has pericardial effusion. You're not going to be like, oh, pericardial effusion. Patient must have rheumatoid arthritis. No, that's not what we're thinking. But we do see these patients at rare times have these underlying conditions. Pulmonary effusions, but the one that really should stand out is this here, rheumatoid nodules. Patients who are rheumatoid arthritis tend to have these rheumatoid nodules. And the only reason why they have rheumatoid nodules is depending on the medication that they're on. Now, you still might see that, but you'll see that another 5 years from now, it'll all be gone. Because the medication that we use to treat rheumatoid arthritis, currently that people are taking right now, causes rheumatoid nodules or rheumatoid lung. And that medication is methotrexate. To be connected later in the later slides. But understand that one of the treatments for rheumatoid arthritis is methotrexate. Yes.
What are rheumatoid nodules?
So they're masses that tending to start coming about in the lungs, and they're caused by the medications you take. You'll go and get an X-ray, and they'll say, "Ooh, a small mass is found." You're like, "Oh, do I have lung cancer?" No. You'll get a CT scan, and you'll start seeing these nodules everywhere. And then you'll force to get a biopsy, and the biopsies will indicate, nope, this is not a mass, this is not lung cancer, but it normally doesn't get to that ever. Because before you go and get CT scans, your past medical history should say that you have rheumatoid arthritis and the patient was on methotrexate. Therefore, additional biopsies are not needed because methotrexate causes pulmonary nodules or pulmonary rheumatoid lungs. Get it? But that's going to be eventually gone, and I'll explain when the time gets there. GI problems, obviously, ischemic valves, we can then see once in a while. Peptic ulcer disease, we tend to see once in a while, and so forth. So, the disease process itself, other things, skin problems, you'll see the nodules on the hands, vascular problems, neurological problems like carpal tunnel, cervical spine instability. You might say, well, why carpal tunnel? Why carpal tunnel? Because in that area, we have a lot of what type of joints? Diaphragmatic joints that have synovial membranes. So in the wrist, you start seeing it right away. Those areas will get affected, and automatically, not automatically, sooner than later, patient will start developing carpal tunnel syndrome. They'll have nerve entrapment, which is carpal tunnel syndrome because of the median nerve. It's causing. Good. And then the eyes, cataracts, dry eyes, and so forth and so forth. All right, let's move on. So I get you guys out of here. So what's actually happening here? We see patients who have rheumatoid arthritis. At times, the disease progression is explosive, and other times it's just very, very subtle. It just depends. But what we do know is once you hit that level, readmission is not uncommon, meaning it's not going to get better. It's irreversible. Once the damage is there, it's not going away. Depending on if it's hitting the heart, fingers, and so forth. Okay? So next question is this. Is it like osteoarthritis where you can simply get an x-ray and see all the problems? No. Rheumatoid arthritis might start off very, very subtle, and you're having all these complications, and you get an x-ray, and the x-ray is not going to show anything. So x-ray is not the way to go for rheumatoid arthritis. Then what is the way to go? Well, the way to go for rheumatoid arthritis is obviously history, physical. After history and physical, x-rays, we'll put the x-rays aside. We'll go straight to blood work. We're going to start off with some light blood work first, like inflammatory markers, like ESR, CRP. Those are inflammatory markers that show that there's inflammation in the body. That's your first one. Then, at times, you might start seeing patients who are anemic. Now, does that mean everybody who's anemic has rheumatoid arthritis? No. But we're starting to build a case. Patient comes in, not feeling good. Joint pain, okay. 1 hour, fine. PIP joints, fine. X-rays, no. Lab work, yes. CRP, ESR, yes. Is the patient anemic? Could be. Reason why is inflamed tissues, they secrete small little proteins that affect iron metabolism. So it doesn't work so well. Erythropoietin production and so forth gets shifted. We should all go downstairs and birthday. We're here. Yes, let's do it. All right. If the initial blood work is okay, sometimes you see anemia, sometimes you don't. Inflammation, you might see it. You might go for a run, you have inflammation in the body. You might say, come on, those are not really good blood work. You know that, and I know that. And I said, I agree with you. Right? You could have fell down the stairs the night before. You have inflammation in the body. ESR and CRP, not so good. So then what is good? Well, RF, rheumatoid factor, which is a blood work that gets done. Is that good enough? It's okay. What do you mean it's just okay? Well, we know that the board's going to ask us to get an RF. That's 100% sure. But what I want you to know is that if somebody who has rheumatoid arthritis, 60 to 80% of those patients will come back positive. Then you might say, well, are you telling me that I'm going to get a false negative? Yes. Because if only 60 to 80% of these patients get it, or it can come back positive, but if you still have the disease, then it's not a good enough test. And I will agree with you. Hey. So then what is? Well, what I'm trying to present to you is this. If you have someone that has rheumatoid arthritis, when you go and test off rheumatoid panel, the panel is going to have ESR, CRP, a CBC to check for your blood count. And then it's going to have an RF. And then it's going to force you to have the newer antibodies in there. These ones right here. Anti-R833 and anti-CCP. They all get bundled together. Therefore, you have inflammatory markers, anemia setting in, and so forth. RF, not positive, but all of a sudden these come back positive, then that means we missed that 20% right here. Okay? These are the newest antibodies that are out there. And they will let you know if the patient has a rheumatoid factor. Now, some of you guys are probably sitting here and saying, I think there's more to it. I think you're right. That you are absolutely right. Because there are other disease processes or other neuropathies, which we'll speak about later on, that also get mixed in with this, like lupus and so forth. When we start talking about lupus, you're going to start saying that, oh, we're still going to order an RF factor? Yes, we are. Because symptoms overlap. And that's what makes everything more confusing. But what you need to understand is how to go ahead and pick and choose the right words to answer the question right. Remember what I told you? A 49-year-old female gets into a car accident, comes into the emergency room, we're thinking something else is wrong. On physical examination, she has Boutonier's deformity, she has Jacob's neuropathy. What they were really trying to tell me is the patient have rheumatoid arthritis? I said, yes, they do. They said, what are you going to order? Not a problem at all. I'm going to order an RF and I'm going to order all these. Got the question. And everything else was fugazi. Not true. Forget about the patient in the ER. Forget about the patient who got in a car accident and flipped over 3 times. They don't care about that. Well, at least in that case scenario, they care. All right. Now that we've diagnosed this patient, now the next question comes into place is, well, what do we do? What do you do with all those things? Well, first things first, rest, ice, analgesics, physical therapy. All those might help. If you notice, all this is what we treat osteoarthritis with. The first line of treatment should be NSAIDs. That's what the American Medical Association wants you to treat them with. And that's fine. If that does not work, Then we move on to the next round of medication. Now, these are the rounds of medication which we're going to speak about that your parents are on and your grandparents are on and so forth. And they're good, but they cause a lot of side effects. So there's a whole other generation of medication that come along. And that's the reason why I was telling you before, you might see a rheumatoid lung right now, but another 5 years from now, it's going to be a thing of the past. But let's get into it. What are DMARDs, or disease-modifying anti-rheumatic drugs? Well, they're much more potent than NSAIDs. Well, then what are they? Well, these are the medications. Plaquenil, sulfalazine, methotrexate. These are forms of DMARDs medications. When you guys get out there, you're going to see your patients on these medications.
They get all three or just one?
Say it again?
They get all three or
No, just one. You pick and choose which one you want. Now, to get an idea of how potent these medications are, does anybody know what we treat Plaquenil with? Malaria. Does anybody know what we treat methotrexate with? Breast cancer, OBGYN issues, yeah. So you might say, wait, I can treat breast cancer with methotrexate and rheumatoid arthritis? Yeah. If I'm treating malaria with Plaquenil, is that okay with someone who has rheumatoid arthritis? Has anybody had malaria here? I haven't. I'm just asking. I don't know, but I've read that it's pretty bad. It hurts, pain, joint pains, and everything, and fevers, and all kinds of stuff. But in an extreme situation like that, Plaquenil really does help. Anyhow, patients are on these medications and are readily on them. The problem comes into place is, why do we need to know them? If they're working, fine. Are they cheap? Yes, they're cheap. Then why? What's the problem? Well, the problem is the side effects. Bad side effects. Meaning, rheumatoid lung, the lung nodules caused by methotrexate, pulmonary toxicity, sulfalazine, myelosuppression, Plaquenil, retinal toxicity, diarrhea, rash. They're bad. Then we have another line, more. Mural, Imuran. So what I'm trying to tell you is be careful when you get out there because you're going to see these patients on these medications and they're going to come with symptoms saying, oh my God, I feel like I'm dying. Well, yeah, because the side effects of these medications is terrible. And I mean terrible. But patients still continue to take them. Gold, oral gold, injectable gold? Yeah. I actually know a patient who has gold mailed to his house. They're in vials, and there's flakes of gold that's in there, and he gets injections. And a nurse comes to his house and gives him the injections. Is that still available? Yeah.
it's expensive.
Expensive? Yeah. Who has gold floating around his body? Somebody's gonna shoot him, just take the gold. You know how much gold is worth nowadays? It's a lot of money. So you get the idea. But gold in your body is not a good thing. It causes a lot of problems. Okay? So just be careful. I think I taught a class like a few years ago. Like, Goldschlager? Can I take Goldschlager? Can you drink that? I'm like, no. Goldschlager isn't liquor. It's not the same. Some of you guys have no clue. Some of you guys are like, yeah, it's not. Okay? But form of DMARDs medication. Once again, some of them are cheap, like methotrexate, sulfalazine, Imuran, Plaquenil. They're cheap medications. They work. Yes, they work. But huge side effects. Now, you might say, well, you keep on saying that you're never going to see rheumatoid lung after a few 5 more years. Absolutely. Because the patients that were on those medications are eventually going to pass away. And the newer line of medications that are used are medications like biological cell modifiers. These medications are the newest lines because they specifically target cytokines. And they bring down inflammation. And it works, and it works very, very well. Are they cheap? No. Do they have side effects? No. They don't have side effects like myelosuppression and all kinds of crazy stuff, and pulmonary nodules. No, they're all gone. All those side effects are gone. The only problem is they're expensive because they're brand new. Eventually, they're going to go generic, and then we're going to have a lot of fun. Okay? So there are some side effects, rashes and things of that nature, but not as bad as myelosuppression and so forth. Now, you might say, well, what kind of medication are you talking about? What are these biological cell modifiers? Have I ever heard of them before? Yes, you have. They're all over the place. Like Remicade, the TNF, tumor necrosis factor A, just falls into a category. It's given IV infusions once every 4 to 8 weeks. The only thing that you have to do is, if you're going to give anybody biological cell modifiers, the first thing that you need to do is you have to make sure the patient does not have TB, tuberculosis. Why? Because somebody who's in a tuberculosis state are immunocompromised, and at times, not at times, they just don't work so well if you're in an immunocompromised state. So those are not patients who don't have good outcomes. But it says in the back of the package, make sure the patient does not have tuberculosis. Enbro, another form of medication, every 2 weeks or every week, sub-Q, depending on the severity of the disease. Now, these medications are great. They work great. Years ago, I had a student here. She graduated from here and she moved upstate to, like, the Niagara Falls area. Her husband was also a PA and they moved up there. He got a really good job in a trauma center over there, and she followed him. She was working in a primary care office, and at the primary care office, she used to run the office all the time. And I would stay in touch with her in the sense that she would call me and ask me some questions about this. And she said, I have like 2 or 3 patients here who have really bad rheumatoid arthritis, and the medications just not seem to work. They have constant diarrhea, and the doctor's been dealing with the diarrhea for years now. And I really want to start moving over to biological cell modifiers. And I said, you know what? You should. I think you should ask these patients if they want to start Remicade. And she said, I would love to do this. Anyhow, small community up there, way up north, and I guess everybody kind of knows each other. All the doctors know each other. So she started treating some of these patients with Remicade, and it worked. They loved it. He came in, got an infusion like every 4 weeks or every 8 weeks, and things were great. In that doctor's office, the doctor was getting old, and he was like, listen, you run the office, you're doing a great job. And she would have like 3 beds like that, 2 beds like that in the back set up, and patients would come in and get Remicade infusions. Everything was great. And the biller passed away, so my office was doing her billing and so forth. So I was kind of like, say, listen, you should do this, you should do this. Anyhow, all the other doctors in the area, for some reason, started sending all of our patients for rheumatoid arthritis. And not just rheumatoid arthritis, but other things like lupus and so forth. So she started doing biological cell modifiers, and one of the things she was doing was Remicade. So what she did was she took over the office next door, and she put more infusion beds. And every day, she said we would have about 10 people that come in to get infusions. And then people in the surrounding areas would come. And she was making really, really good money. And I said, well, why are you telling us this? It's Friday, I want to go home. Why are you talking? And I want you guys to start thinking outside of the box. Even though you guys are mid-level practitioners, that doesn't mean that you have to stay in the realm of mid-level practitioner. You might think that you're a mid-level practitioner and you can just work for a doctor, you work for a hospital setting. 99% of you guys will do exactly that. You're going to go work for a doctor or a hospital. You're going to get paid, and that's it. Every time you want a raise, they'll give you like a $1.50 raise every couple of years. You're going to think, oh, thank God. I want you to think outside the box. And it's a perfect example. She goes up there, she starts doing Remicade. She does an infusion and so forth. And Remicade is something called buy to bill, which that's a whole nother story. But she was making around $1,800 to $2,000 per infusion. And she was doing about 12 to 13 infusions a day. So can you imagine the amount of money she was making? Now she has a whole infusion center up there, and all the people come to her, and she's starting all the kinds of stuff. She does like Xolair and all kinds of stuff. We still do our billing, and she doesn't make $140,000, but you're going to be working for Catholic Health Service in Norfolk. You see what I'm saying? Like, we're talking about in the millions. Okay? So what I'm trying to tell you is, if she can do it, why can't you do it? Get it? And I think you should, but nobody's going to listen to me because you guys go, I got a job in Norfolk. I can't wait to start. It's all good. Okay. All right. Other forms of biological cell modifiers, obviously Humira and things of that nature. Once again, some of them are slightly different. And the reason why I'm putting them on here is because they fall into different categories. It's not going to be on the exam. I'm not going to trick you and ask you, hey, tell me about these biological cell modifiers. Humira, is it an IgG1 or a TNF-A? I'm not going to do that. This is for your own knowledge, so that way when you guys get out there, you understand. And the reason why I put this on here is because I want you to see how marketing works out there. You can see this and be like, oh, I don't know what that is.